This is Charles Denham. I am Chairman of TMIT and would like to welcome all of you to our webinar today. This is the third of a four-part series that we've partnered with the Centers for Medicare and Medicaid that really began with a meeting that was hosted by the Centers for Medicare and Medicaid for the quality improvement organizations. We know there are a number of competing webinars today, but we also know that a number of our organizations across the country are recording this, and we know we have a number of folks in auditoriums today. I'd like to take you to slide 3 and just remind everyone that if you're having difficulty with your audio connection because we have such high traffic on this webinar, you may click down on Request Phone and get a separate phone line to be able to participate. The next slide is slide number 4. I'd also like to remind you to go to safetyleaders.org, www.safetyleaders.org, to download the slides in PDF form, and also remind you that on the website a transcript and audio recording as well as the slides will be available on our website. And if you go to slide 5, those of you that are on the slides, you'll find where you'll be able to download that. For those of you that are not on yet, go to www.safetyleaders.org. We really are blessed to have a tremendous set of speakers today. Again, we're going to go in a rapid, dynamic manner with short presentations from each one, but we always start these webinars not with tokenism or not with just a symbolic input from patients and families, but really from our patients and families across America. Give them the opportunity to be represented by someone to ground us in the context of what we're really about today in the webinar. I'd like to turn the mic over to Dan Ford. Dan will express the voice of patients and families. Dan is an absolutely terrific patient advocate. We've worked very closely with Dan for years, and Dan is also a specialist in the healthcare industry in that he helps provide us leaders for organizations. And Dan has had the experience of a harmful event in his family and knows both sides of the coin. Dan, would you start us off with your voice of the patient and family?
Thanks, Chuck. I appreciate being involved. This is an absolutely phenomenal webinar subject matter with phenomenal speakers, and it's another opportunity for emphasizing the value of the partnership between patients and providers as well as with the purchasers and the payers. As you noted, my day job is an executive search consultant. My full-time passion and much personal activity is as a patient safety advocate because of that family medical error tragedy that has had lifelong impacts, and I don't want to see this to happen to anybody else. It still does, but we got to minimize it. Hospitals and doctors are not yet totally on board with true patient and family-centered care and inviting active patient involvement. That is a true partnership, even though many have this goal. And purchasers and payers are in a great position to leverage safe and high-quality care as well as patient and family involvement. After all, the patient is the common thread throughout the entire patient experience. And I look forward to hearing the speakers. Thank you.
Thank you so much, Dan. We really appreciate all that you have done and contributed to in healthcare, and we'd just like to make sure that we move to slide 7, and you may review our disclosure statement of all of our speakers. No products and services will be promoted during this webinar, and we'd like to then take you to slide 9. Our mission is to save lives, save money, and build value in the communities we serve. We can think of nothing higher or more of higher priority or importance than to partner in patient safety and quality with the purchasers of healthcare that are the consumers, the employers, the intermediary, private healthcare plans, and our federal government. Our panel of panelists I'll introduce individually. However, on slide 10, we have Joe McCannon, Special Assistant to Dr. Don Berwick, our leader of the Centers for Medicare and Medicaid, Dennis Wagner, the acting director of the department in Medicare for measures that they use in measures, Dr. Paul McGann, who is the acting chief medical officer. All of these are stellar leaders that defy any one's preconceived notions that government don't have some of our greatest leaders in the world. We have Dr. Alan Korn, who is on travel and pre-recorded a session or a comment to us. And then we have two of our nation's leading CEOs, Mr. Mike Critelli and Mr. Bob Chapman, from two great companies who will give the perspective of really the message that we need to be thinking about from truly empowered leaders that are empowering their own staff and really have high expectations of us as providers, because the folks they care for are the ultimate purchasers. I'll move to slide 11 now and just remind us that we've had recent confirmation of harm in America. The OIG report, the Office of the Inspector General, confirmed in December using the global trigger tool co-developed with the Institute for Healthcare Improvement, and great visionary leadership by Dr. David Klassen, undertook a multi-state study that found that we have as many as 15,000 deaths per month of our Medicare beneficiaries. Other studies that we've reported on this webinar series have revealed that our Medicare beneficiaries, if admitted to hospital with a medical illness, have a 2/3 probability of either being dead or readmitted within a year. And that work by Dr. Jenks of CMS was not a sample, it was of the entire beneficiary database. So this study complemented that. We had the New England Journal of Medicine study by Dr. Chris Langren that showed that one of our more progressive states, North Carolina, has had flat improvement in patient safety over 5 years. And the recent Health Affairs article by Dr. David Klassen that has shown us that the harm may be 10 times what we thought it was by conventional measurement measures. And so on slide 12, we use this graphic to describe why this is happening in America. And as you look at the lower arrow, you see that adverse events and system failures, not just the smaller amount of medical errors, but really the system failures, are increasing, and the adverse events are increasing exponentially, and yet our safety programs are only improving on a straight line. So we have a logarithmic expansion of harm, which means we really are poised to have to do some very dramatic things to get into what we would call good care, and what some of our really great organizations in America are delivering great care. But it will take dramatic measures by very engaged leaders. The next slide is slide 13. We just want to emphasize that great care and safe care is at the intersection of not just technologies and practices, but of engaged leaders, and that's why we've got some terrific leaders on this webinar. Again, we want to remind the audience that this webinar is, if you will, a menu or a teaser menu of a deep dive that we'll take in partnering with purchasers. If during a poll later in the webinar, this audience believes that they like a deeper dive on specific cases for partnering with their private purchasers and the government, that will undertake that. But we believe that the intersection is at the point of engaged leaders, practices, and technologies. The next slide, number 14, is a setup to Joe McCannon, and this is the recent announcement by Secretary Sebelius and Dr. Berwick, with much work undertaken by Dr. McGann, Joe McCannon, and Dennis Wagner, that are just three of a huge army of folks that have been really focused on patient safety and quality. Their news release Tuesday, April 12th, addresses the Partnership for Patients. And if you go to our safetyleaders.org site, it'll link you right over to the government site where you can download the news release. Also see the map that I'm showing on slide number 16 of how many organizations have stepped up to partner. I will not, I think Joe can really describe this to us and put it in the context of partnering with our purchasers. So Joe, I'll turn it over to you. Joe was one of the senior executives at the Institute for Healthcare Improvement. We've known Joe for a long time. He has been an absolutely terrific and enthusiastic social entrepreneur and champion, and we're really honored, Joe, to have you in our government helping us become innovators. Joe?
Well, thanks very much, Chuck, and it's a real privilege to serve and to have the opportunity to continue to do this work that I've been doing here for the last decade or so to try to reduce harm and provide reliable continuous, seamless care for patients and for their families. It always helps me when we begin these calls to hear the words of someone like Dan Ford to sort of return us to our mission here and our purpose here and the reason we do this work, and that is because as we speak here today, we know that there are patients being harmed and that there's frustration and complication in the course of the care process, and there but for the grace of God go we. I think the hard reality that all of us who work in this field realize is that our loved ones who go into care are subject to harm and risk, and we really need to redouble our efforts here and focus on solutions that are more sustainable and that will lead to a step change when it comes to solving this problem. The initiative that Chuck referenced is the Partnership for Patients, and the Partnership for Patients was, as he noted, launched by Secretary Sebelius last week, and is a national effort that first embraces the problem that Chuck described, which is that we have a system that's rife with complication and waste and harm, as documented by all of the studies that he shared, but also acknowledges that we have pockets of tremendous success around the country. We have providers in individual organizations in states like North Carolina, which Chuck mentioned, that are working very, very hard trying to find a way to solve this problem, and in some cases making tremendous progress. We have pockets of success where we've seen significant drops in infections and medication errors and surgical complications, and these all lead us to believe that this is not an insoluble problem. It's actually a very solvable problem. The issue is simply that we have to figure out how to take what works in some isolated cases and make it the norm across the country. And so that combination of frustration with the problem and yet optimism associated with these great examples of success really drives us in this work. Equally, we know that providers of care around the country are very devoted, very committed, and want nothing more than for care to be highly reliable. And so we want to tap into their experiences as well and tap into their passion and devotion to their patients, and understand that they're operating in complex, chaotic systems, and create opportunities for them to avoid the types of harm that those complex systems and our own human fallibility will sometimes introduce. With that as prelude, the Partnership for Patients says we want to try to accomplish two things. First, we want to see if nationally, collectively, we can reduce preventable all-cause harm by 40% over the next 3 years, which we think will lead to significant reductions in injuries, as many as 1.8 million injuries if our projections are correct, and about 60,000 lives saved if we are to achieve those goals. Equally, we want to focus on improving care transitions, ending complications in care, with a targeted goal of reducing readmissions by 20% by focusing on preventable readmissions. And here again, I think we would see significant reductions. Our estimates are upward of 1.5 million readmissions. Preventable readmissions might be reduced in the course of this work. The associated financial benefit, of course, is not insignificant, and that's something that we consider here very closely as well. This starts with focusing on reducing harm, but also making our healthcare system more sustainable and allowing it to grow and provide even better care. And that sustainability is another part of our focus here. Our estimates are that if we were to achieve these goals, we have the potential to save as much as $35 billion to the healthcare system in the next 3 years, and to have significant savings to Medicare and Medicaid as well. So that gives us our focus. The question, of course, then is, okay, well, how will you do this? How will these goals be achieved? And the first answer, and I think the important answer in the context of today's call, is together. There's no way that the federal government does this alone. There's no way that providers do this alone, that plans do this alone, that employers do this alone. We all do it together, and we've seen terrific collaborations all around the country, some of them spearheaded by some of the speakers you'll hear from today on the call, that give us a great deal of confidence and really allow us to understand what's possible. And so we will tap into all of that terrific work that's happening in the private sector and join together very closely to build on that. We also know that we need to build will for change, to raise awareness about the problem, to raise awareness about incentives for change, including payment incentives and regulations and forms of transparency that are part of the Affordable Care Act. But finally, we need to make sure that we introduce technical supports and provide resources and tools so that providers of care and organizations can study great examples of success, learn from one another, enter into structured learning environments where they can have clear aims and expectations for adapting new ideas and practices on a weekly basis. That kind of structure and that kind of environment is part of what we hope to provide here. The Partnership for Patients introduces as much as $1 billion in supports of that kind, $500 million in the Community Care Transitions Program, Section 3026 of the Affordable Care Act, and those opportunities to apply at the community level for those supports are available and are linked from the Partnership for Patients website that you see before you. Equally, the Innovation Center at CMS will also be introducing a set of supports to improve in-hospital care, focusing on creating national learning opportunities, but also local learning opportunities through state consortia and systems and associations that will allow for and foster local supports and local improvement. Patient and family engagement is on the agenda there from the Innovation Center as well, making sure that we create opportunities and environments for patients and families to engage in this work, to raise their awareness, but also give them very concrete ways to take part in redesigning care and have a stake in improving their care by tapping into tools and resources like discharge plans and medication cards and other similar supports. So there really is, I think, a wonderful opportunity here in joining with the private sector to build on this work. We know that the best examples of success that we've seen are in communities where every stakeholder in the care process, payers, providers, purchasers, patients, and families are all coming together around the same table, and at a policy level we support that conversation and those opportunities for learning in order to drive change. And so that, I think, hopefully sets the scene for what you're about to hear here today, which I think is a terrific set of stories and case examples and ideas about how we can progress on those fronts. To join us in the Partnership for Patients, you simply need to sign the pledge, which is available from the website, and we'd invite you to go to that website, learn more about the initiative, and sign on publicly. So thanks very much, Chuck, for this platform, and I'll allow you to move on to the other panelists.
Joe, I know you've got just pressing. It's crunch time at CMS, and we know that, and we know what great work you're doing. We know you can't stay for the Q&A, and I've got a very careful flight plan minute by minute. I'm going to take a little bit of the time from our Q&A session, knowing that you are getting called away. Joe, could you just maybe give us connect some dots for us? Connect this program with value-based purchasing and accountable care organizations, because there's so much anxiety out in the marketplace, and really these fit wonderfully together, and most people don't realize that. Could you just connect a few of those dots for us at, the C-suite sort of level?
So, Chuck, you're asking how will the initiatives in the Partnership for Patient relate to other sort of healthcare delivery systems? How they reinforce
and fit. Yeah, how they reinforce and how they fit together with the value-based purchasing and the ACOs.
Well, I think that the Partnership for Patients represents an opportunity for organizations to either continue their work or get started on reducing harm and improving care transitions. And I think reducing harm and improving care transitions are great entry points to the other programs or incentives that you describe. In order to prepare for hospital value-based purchasing, organizations need to have a safe space or an environment to work very, very intensively on reducing harm, and that's what we're creating here in this initiative. Equally, if you think of new care delivery models like accountable care organizations, we know that creating infrastructure and successfully managing things like improved care transitions prepares organizations for those even more significant programs to reduce fragmentation and managed care populations. So I think that there's a very, as you suggest, a good progression there. But we strongly encourage all facilities and communities around the country to get started now in these areas, because we think it will really prepare the way for what's to come.
Thanks, Joe. We know you need to go, and we're going to move next to Dennis Wagner. But thank you, Joe, for your commitment and the concerted effort to integrate these things. For those of us that have dug deeply into them, they really do have a powerful reinforcing message and a simple one, which is we really need to be safer, and that there are great opportunities, and there are high performers that we can learn from. So thanks, Joe. We really appreciate it.
Thank you, Chuck.
I'm there. Chuck?
Yes.
It's Paul McGann.
Paul, would you like to, with your constraints at CMS, would you like to go ahead of Dennis Wagner or after?
I'm sorry to interrupt, but I'm going to be called away here in a few minutes, so maybe I can, I'm familiar with Dennis's presentation. Maybe I could just spend a couple minutes setting him up, and then you can get on with your schedule.
Terrific. This is Dr. Paul McGann. He's taken time away again from crunch time at CMS. He's the acting CMS Chief Medical Officer for the Centers for Medicare and Medicaid. Most importantly, he's a physician that can put together this detailed work in government and really give us a great and inspiring message of focusing on patients and safety and quality, and really can connect the dots. And it's been an honor to serve with you, Paul, with QIOs, and we're excited about where you're taking us going forward. We'll let you kind of, to some degree, tie what Joe has said to what you know will follow from Dennis Wagner. Paul?
Yeah, thanks very much, Chuck. And I also want to thank TMIT and all the other panelists for the opportunity to reach this very special audience that we have today. You're going to hear in a few minutes from one of the great masters in the United States of putting together large, innovative, change, collaborative efforts at a national scale, and that's Dennis Wagner, who I'm proud to say is my partner with the Office of Clinical Standards and Quality. His remarks have been pre-recorded because the schedule didn't permit him to be here today, but I wanted to kind of set this up because I think some of the things he's saying, and he has a little slide deck to go with it, are powerfully important, and most of all, I've been at CMS for 10 years now. They're very, very different than anything that our agency has ever done in the past. So we're so pleased that you've all joined us to sort of hear the big change that's happening at CMS just over the last few months. Joe McCannon has just eloquently, I caught most of his talk just now, he's eloquently explained the launch of the Partnership for Patients last week. I work in the Office of Clinical Standards and Quality, and together with Jean Moody-Williams, I'm sure you're all familiar with the QIO program. We just began the procurement this week of the QIO 10 scope of work 3-year contract, which will be awarded and begin on August 1st of this year, so that's yet another element to this plan. But I really wanted to focus on what Dennis is going to tell you in terms of collaborative improvement efforts and the importance of alignment. Dennis is really going to focus on what alignment means and how to achieve it. And I want to build on what Joe said by telling you that my opinion is that the most important aspect of alignment is to have specific aims, specific quantitative goals that we're striving to achieve. They should be stretch goals. A really good goal is something that someone would put out and the first reaction from the field would be, well, that's impossible, we can't do it. And Joe explained to you that in the Partnership for Patients, we're just stating the goal up front that we're aiming over the next 3 years to experience in this country a 40% reduction in all-cause patient harm in the hospital environment. And we're also reaching to achieve a 20% reduction in preventable admissions. And these aims have been now duplicated and emphasized in all of the major quality improvement programs within CMS, Medicare, and to some extent Medicaid as well. So we're trying to reach out to the rest of the community outside of government insurers and the private partners, and that's why you're here. And imagine the power of aligning these aims across all the programs, both public and private, and all the quality improvement efforts, if we can all subscribe to these really bold national goals over the next 3 years. What we're going to do is get those goals that are already in the 10 scope of work contract into all the new innovative programs that are coming out. We're working as an executive team at CMS to ensure that the same goals and the same methods of measurement are duplicated throughout all of our many disparate programs that normally arise up in siloed categories that don't talk to each other. Some of these special organizations that I think we can achieve this alignment in, you've discussed some of them already. I mentioned the QIO 10th scope of work. I heard some discussion from Chuck on the accountable care organizations, the rule of which was just released a few weeks ago. In addition to that, there's ACA Section 3026, which is a community-based care transitions program, which was also just announced in the last couple of weeks. We also are working to try as hard as we can to align with our Medicare Advantage managed care organizations. I'm sure you heard just in the last couple of months that the OSIO, the Office of Consumer Information and Insurance Oversight, has been brought under the wings of CMS as well, and there's vigorous activity going to align quality improvement goals and measures with that office, which is going to set up the exchanges, the healthcare exchanges that add to the spectrum of insurance for Medicare, Medicaid, S-CHIP, and now the exchanges. We also have innovative programs that are building and aligning as well within Medicaid. So Medicaid is changing. There's a special emphasis on attending to the needs of the dually eligible population, where the quality improvement activities are expected to yield just tremendous improvement in care and achievement of the three-part aim from Don Berwick, our administrator. We also want to just pause and emphasize the fact that things that have really not been emphasized in Medicare ever in its 40-year history, things like the promotion of preventive health care and trying to get ahead of the curve of illness and prevent illness from developing in the future, and also attention to programs dedicated to achieving and promoting healthcare equity and reducing the healthcare disparities that still exist in our programs. These are also additional aims that we're adding and aligning in all of our programs. But most of all, what I want to emphasize is that today, at this time, is a time of great change. I don't think, although many cynics do come forward and say, well, this happens and it's just the flavor of the month, but I can tell you from working at CMS for 10 years, this does not feel at all like the flavor of the month. This is a time of fundamental changes to our healthcare system, of unprecedented cooperation and collaboration. Dennis is going to get into some of the details of that, but I want to leave you with a really inspiring story. As you know, Don Berwick, our administrator, is quite skilled at the science of change and of organizational change, and he's instituted a bit of a culture change within our organization. I just came back from the 4th all-staff meeting of a quality improvement course that Don Berwick is teaching for all 4,500 employees of the agency. And Chuck, you'll relate to this. The lead speaker in today's course was Josie King. So we're actually, for the first time in my experience, bringing patients into the agency here in Baltimore and having all staff meetings where the patients are telling the staff of CMS, Medicare, Medicaid, the story, in this case, of really tragic and avoidable patient harm. And the audience was spellbound as Josie King told, or her mother told the story of what happened to Josie. And Josie got a standing ovation, Chuck, at the end of the presentation. So this is really different. It feels different, and it is different, and I think it's a unique opportunity. And I really hope that 2011 is going to be the year when we all join on board and learn how to collaborate and how to align ourselves around the various aims. So that's my main inspirational story, Chuck. I think it's a really exciting one, and I'm very grateful for you to have arranged this and to have the people that you have on today's webinar.
Well, thank you very much, Paul. You're doing a terrific job at CMS, and I think the one thing we've all seen is that this is not Grandma's Medicare any longer. There are dramatic and bold aims. People are bringing, as you say, patients in no small part you and Dennis, Joe, and Dr. Berwick. So thank you very much, and thank you for taking the time between the crunch meetings to do this for us. We have a number of folks on, and we have a huge number that are recording this because there are dual webinars going on across the country because of so much action. So thank you so much. I'd like to now introduce Dennis Wagner. This has been recorded, but Dennis I will tie the slides to what Dennis has said. Dennis, we have worked with Dennis through the last 4 presidential administrations and have actually seen the methods that you'll be describing and some of the concepts work. One most noteworthy, and I want to keep us on time, so that I just want to mention that the organ donorship program that then ultimately allowed us to write a national safe practice was led by Dennis. It saved 4,100 lives in the first year, and to date, we've just crunched the numbers, has saved 10,000 lives, moving the number of people that are on the waiting list for organs in America from 92,000 to 105,000, and still 17 people die every day waiting for an organ. Were it not for this social entrepreneurship of this one great leader with a great team, it wouldn't have happened. So, Kyle, would you please roll tape on Dennis? Our next speaker is Dennis Wagner. Dennis is the acting director of the Measures Division for Medicare, for the Centers for Medicare and Medicaid. I've known Dennis many years. Dennis is one of the greatest social entrepreneurs that we could ever hope to be in this position, and Dennis will speak to us about partnering and aligning the forces and teaming together in partnerships between purchasers and providers. Dennis?
Thank you, Chuck. I am delighted to be part of today's call, representing CMS as the Acting Director of Office of Clinical Standards and Quality, and I'm delighted to be part of this panel of speakers together with my colleagues Joe McCannon and Paul McGann, the Acting Chief Medical Officer, employers, Blue Cross Blue Shield, and other folks that you've assembled for the call, Chuck. Thank you very much for including me. I'm going to take just a few minutes, as Chuck said, and share the CMS OCSQ perspective on this business of alignment and partnering. And I think everything really starts, my first slide is entitled CMS Vision. This comes directly from Administrator Don Berwick. This is his vision for the agency. It is a vision that OCSQ has completely and wholeheartedly adopted in every part of our work. We embrace this. And that vision is CMS is a major force and a trustworthy partner for the continual improvement of health and healthcare for all Americans. And that, I think, is a new standard of accountability for CMS. It goes beyond being a payer. It goes beyond being the nation's largest insurance company. It goes beyond accountability for the Medicare and Medicaid programs. It really is all about now holding ourselves accountable for health and healthcare, which is a much higher degree of accountability than simply implementing programs. It makes us far more accountable than we've ever been in the past for what really happens to patients, what their experience of care is, whether their health improves, and also what costs are associated with the care that they're receiving. So that is absolutely key to our vision. Now, if I could have you turn to the next slide, because this is all about alignment, I think it's important to kind of sort of discuss who are we seeking to align in this work that we're doing to achieve the CMS vision. And I've outlined here, I think, some of the key elements of where OCSQ and CMS is focused on in terms of alignment. We need to better align the Medicare and Medicaid programs. We need to align those programs better with the private payers, like some of the folks that are on this call. I'm delighted that Blue Cross Blue Shield is part of today's call. We need to do a better job of aligning the programs and the work within the different agencies of the U.S. Department of Health and Human Services. I've listed 3 here: the Agency for Healthcare Research and Quality, Carolyn Clancy's organization, the Office of the National Coordinator, the work that they're doing under the HITECH Act and bringing electronic health records to patients and Americans throughout the country, and of course CMS, but there are others as well. We also, I think, have to do a better job of aligning our work with key partners. The American Hospital Association, the Federation of American Hospitals, consumer groups, the Joint Commission. There are a lot of folks that are directly involved in this work of improving care, improving health, and reducing costs. And for us to do it properly, we need to be working well together, because the bottom line is really the bottom line that you see on the slide, to improve things for providers and patients. So I think the who here, these are some of the big aspects of the who. Now, if I could go to the next slide, Chuck, the next, I think, major piece of alignment is the what. What are we seeking to align? And I would say that the first thing that we're seeking to align are our aims. And Don Berwick, our administrator, and I know that probably everyone on this call knows Don Berwick and is familiar with the three-part aim. And those aims are a guidepost for all of us as we do our work: better care, better health, and lower costs. And specifically, a couple of emerging goals that have come out very recently in the major announcement that the Secretary and Don did last week are reduced readmissions and fewer health care acquired conditions. When we generate results on those two specific aim areas, we are generating results in all three parts of the three-part aim. I think another key aspect of what we need to do is better align our measures for plans, measures for individual providers, measures for hospitals, and for others. And I'm going to talk a little bit more about that in a few moments. And then I think the third major what here that we need to do a better job of aligning are the various programs that govern the work of provider and provider organizations. I've listed just two examples here. We need to have much better alignment between the e-prescribing program and the meaningful use work. This has been a source of great frustration for providers, and we are doing everything that we absolutely can at CMS to do a better job of aligning those programs. And we intend to announce some improvements in the not-too-distant future that would outline some of the ways that we're seeking to make these programs better aligned and easier for providers to implement. We also are on the cusp of announcing the final rule for the hospital value-based purchasing programs, and we are seeking in every way possible that as we measure the quality of hospitals, that we are aligning the program measures for hospital value-based purchasing with measurement programs that already exist on quality reporting programs like the Hospital Inpatient Quality Reporting Program and others. There are a lot of other areas that we need to do a better job of aligning, but this is kind of, I think, big picture, some of the what. If I could have the next slide, Chuck, and this gets to, I think, the more challenging aspects of this work. How do we bring about this alignment? And I think at a very high level, we bring about this alignment through kind of four things that I'm gonna talk about for just a couple more minutes here. The first is because we choose to do so. You know, there's a wonderful paradigm that was put forth by a very celebrated philosopher and author named Viktor Frankl, and he talked about how what makes humans human is that you have a stimulus, and you have a choice, and then you have a response. Now that's different than what happens with animals or what happens with science, where you have a stimulus and a response. As humans, we have an opportunity when we encounter a particular stimulus to choose how we respond. And I think on this business of alignment, we can do a better job of aligning programs, aligning aims, aligning measures, and the other elements of our work in American healthcare if we choose that we're going to make that happen, that is a conscious and deliberate choice. I think a major aspect of how we do a better job of aligning is around aims. Aims like the aims that the Secretary and Don Berwick announced last week with the Patient Safety Campaign. That gives us a way to align our work that's entirely different than by functions and by programs. A third way that we, I think, can align or do the how is through deliberate, intentional collaboration. And collaboration is a conscious alternative to at least 4 other behaviors that we could be pursuing. And I'm going to share one additional slide on that in just a few moments. And then finally, I think a key way that we go about aligning is through the deliberate and intentional use of requests and offers. Requests and offers cause action among people and among organizations. And if we can be systematic and deliberate about the use of requests and offers, it presents us with a tremendous opportunity, I think, to do a better job of aligning our work across all sorts of different organizations inside and outside of government. Now, if I could have the next slide, Chuck, you'll see here a very straightforward paradigm that basically outlines what collaboration looks like as a deliberate behavior that's an alternative to at least 4 other behaviors. Now, the way to read this chart, you see on the left-hand side of the chart, we have you. If you could think about this as sort of whether you win or whether you lose, you win if you're in the upper part of this chart. You lose if you're in the lower part of this chart. Now, there's the other guy, all right? What's happening with the other guy? As we do our work, the other guy can lose or the other guy can win. And what we're seeking as a deliberate strategy in our work to align the American healthcare system in better ways to the benefit of providers and most especially to the benefit of patients, we can make a conscious choice to be in the upper right-hand corner of this quadrant where you win and the other guy wins. And the behavior that goes with that is collaboration. Collaboration is all about communication. It's about understanding the perspectives and the goals of the other party and being clear about your own perspective and your own goals and your own aims. And when those things are vivid and clear, that's the groundwork of the foundation for win-win behavior. It's what OCSQ is seeking to do with quality improvement organizations as part of our work on the 10th scope. It's what we're seeking to do with our development of quality reporting programs, our development of measures, our implementation of the hospital value-based purchasing program, and all the other aspects of the work that we lead here at CMS. We are seeking in every possible way to collaborate. And that is a conscious alternative to these four other behaviors that you see here. Competition, when you win and the other guy loses. Compromise, when you both kind of get half of what you want. Capitulation, when you let the other guy win and you say, I'm going to lose. Or avoidance, the lose-lose or the worst behavior. We are seeking consciously and aggressively in our work in OCSQ and CMS to be collaborative, alternative to at least four other behaviors. Now, if I could go to the next slide, this is kind of a setup for the final how that I'd like to share on the call today. Leadership Speech Act. I don't know whether Speech Act is not a common term that most of us, I think, encounter in our everyday life, but it turns out that there are a number of very powerful speech acts that as leaders, each of us implement kind of day after day after day. And what I'd like to focus on are request offers as a deliberate way of achieving alignment. If I could have the next slide, Chuck. Anyone who has ever had a child or been around a child is very familiar with requests and offers. It's something that we learn to do from the moment we're born. We make our requests clear, and hopefully someone's there to sort of fill in and help us with those requests. The thing about requests and offers as a deliberate leadership speech act is that they cause extraordinary things to happen, especially if you pursue requests and offers with system and method. Chuck, you started this call. You actually offered to conduct this webinar at the QualityNet conference that occurred in December of 2010. We're here today on this call because Chuck made an offer to the quality improvement organizations that were assembled at our annual meeting, QualityNet, and you made an offer to CMS to team with us in the conduct of that call. And you, in that moment, created the future. We're on this call today, Chuck, because of what you did, the offer that you made. Requests and offers unlock natural abundance. We wouldn't be having this call if you hadn't done that. And this is a wonderful thing, the people that you've assembled, both as speakers on this call, but also in the audience. Requests and offers knit us together, and they generate action among people. That's kind of at the heart of collaboration. And I think that if we can get skilled, better skilled in the government, in CMS, in the different HHS agencies, in the quality improvement organizations, as providers, as patients, if we can get better and better at systematically making requests and offers with each other and knowing that they generate abundance, they generate action, and they knit us together, I think that is the second major how. So with that, it kind of takes me to the last slide. I want to end where I begun. We are deeply committed to Don Berwick's vision for CMS, that we would be a major force and a trustworthy partner for the continual improvement of health and health care for all Americans. I'm delighted to have been part of the call today, and I thank you. Chuck?
The honor of collaborating in some small way, one way or another, in about 4 different social entrepreneurship endeavors with Dennis through multiple administrations, and have seen the power of some of the tools that he's addressed. Thank you very much, Dennis. And as we poll our audience to ask them whether they'd like a deeper dive in some of these concepts, I feel sure we're going to have 100% saying they want to move forward. Dennis, thank you very much for participating.
Thank you, Chuck.
So what we'd like to do now is have you, the entire audience, and for those that are on the pre-recording, indulge us for just a moment. In the lower right-hand corner of your screen are poll questions, and you've just heard very, very high-level concepts from Dennis. We're going to undertake 2 deeper dive webinars in this topical area of partnering with your purchasers of healthcare, and we would be addressing these concepts in the deeper dive as we go forward. Just a recap on the organ donorship program. I'll never forget giving a keynote to the 2,000 people across the country and from all the transplant centers that Dennis assembled, and that we as a common leadership team addressed, and seeing tears in the eyes of transplant surgeons that are very hardened by what they do, and actually see them get in touch with their heart, their mind, and move their lips and their hands to action. These social entrepreneurship skills are critical, and knowing how to improve safety just is not enough. I'd like to move to a short clip from Alan Korn, a 3-minute clip from Alan Korn with a message from Blue Cross Blue Shield. Dr. Korn, you have spoken very eloquently and specifically about trust and how important trust is to relationships, and as we look at partnering between purchasers of healthcare and providers. Can you address this issue of trust and what you mean?
Yeah, it'd be my pleasure. You really can't make substantial progress even in a business relationship without trust. In a business relationship, we often sign a contract which codifies the trust and means that we actually now are obligated to do what we said we could do. In the delivery of clinical services, there are no contracts. But because physicians take oaths, there is a tacit assumption between those of us on the purchaser side and those on the provider side that it is binding and that we trust that all things will go well. Somehow that trust has been disrupted. Business issues, first of all, corrupted the clinical trust that we hope to develop with our provider community, and we became embroiled through years of first DRGs and then HMOs, and having sorted all of that out, we're left with a legacy of distrust, and so that needs to be repaired. The Blues have, I think, made an extraordinary effort to rebuild trust, and often when we approach organizations, entities, societies, etc., we'll begin that relationship, at least on our part, by trusting first, to demonstrate our steadfastness, our commitment, and our integrity. Having established it, we then now need to look at the organizations and find out if that trust will deliver the results that we hope. And to date, it hasn't. The safety data are clear. And I hasten to say that it's not because of any bad intention. Providers want to provide good care. They want to provide safe care. And when they are made aware through data or other means that things that shouldn't happen, their immediate response is to try harder, meaning they're more rigorous and vigorous in doing what they've been doing, but that hadn't worked. And so what we would hope to do with the new form trust that we now have with a number of organizations that transcends individual hospitals and practitioners, but various specialty boards and others, is to create an opportunity for physicians and hospitals not just to work harder. They're already working hard, and doing more of what isn't working and doing it with more passion is unlikely to fix it. We would hope to provide the resources to these hardworking and often overworked colleagues to lead them down a path to better outcomes, safer outcomes, and at the same time more affordable care, which is certainly a part of our dilemma nationally today. So trusting is where we begin, and then we have to deliver the goods. And the goods are the tools, the resources to make care safer so that those on the front line in real time have the decision support and the resources necessary to achieve the outcomes to which we all aspire.
So we've shuffled the deck a little bit with the CMS constraints and pressures. So we'll now move to Mr. Michael Critelli. Michael is an absolutely terrific leader in America. I remember the first time I met him as the former CEO of Pitney Bowes, and having such a passion for healthcare and really a deep intrinsic understanding of what it really takes to deliver great care. And it's been an honor to be a senior fellow at Harvard with him in advanced leadership. Michael, take it away.
Thanks very much for those kind remarks, Chuck, and I'm very honored to be here today with this distinguished panel. Employers pay a big chunk of the healthcare bill in this country, second only to government, but they have really under-leveraged their capability. And what I hope to do today is give you a little background on both why that's happened and why I am more optimistic that that can change. First of all, I think the employers are feeling more pain than ever in addressing spiraling healthcare costs. And what they've come to realize in the last year is they will not be rescued by healthcare reform, by the government, by any other source. They will continue to pay the bill. Secondly, one of the good features is that consumer-directed health plans, which are the fastest growing part of the employer-based healthcare system, create for the first time a meaningful partnership between employers, employees, providers, and the rest of the healthcare system. That's a good news story because now employees have to think about both cost and quality in a way that before it had been somebody else's responsibility. For a number of years, employers thought that the solution would come from excellence in the third-party administrator system. They would go to the major health insurers that were doing disease management and care management and big case management. But as the 2011 Towers-Watson survey indicated, they're not only highly dissatisfied with third-party administrative value delivery, but they've come to realize that they really have to be hands-on. Healthcare quality improvement and cost reduction cannot be outsourced. May we go on to the next slide? Why am I a believer? Can we go to the next? There we go. First of all, employers do have leverage through their health plans. And a long time ago, Pitney Bowes, with very primitive data, that was my company, decided to favor high-performing institutions with better safety records. We never took away choice, and I think that's critical to successful programs, whether it's through employers, insurance companies, or the government. People want choice, but you want to nudge them toward the better choices. And so we both increased the reimbursement for Center of Excellence and patient safety, and we provided that's to the providers, and we also gave the employees and their families incentives to use those centers of excellence. The other thing we did, particularly in difficult areas like mental health and more recently obesity management, is we put in an incentive which on the face of it was an ad as opposed to a takeaway. So we told people, for example, in mental health, we are going to eliminate lifetime caps, we are going to eliminate annual caps, and we are going to raise your reimbursement from 80 to 90% if you go through 8 free-of-charge visits with our provider of behavioral health counseling. Now, the real underlying purpose of that was to direct people to the right care for them. We replicated that model years later with obesity management to steer people away from dangerous surgical choices because we were experiencing a very high percentage of people getting complications. And the good news is that in both cases, we had higher satisfaction and lower levels of healthcare cost increase. We also believe that employers, if they are going to continue to work with third-party administrators, can drive them toward focusing on patient safety and negotiating prices and whether someone gets a preferred position in a network. So there are a lot of positive signs in where employers are going. Now, why hasn't it moved faster? First of all, one of the worst enemies of better management of health is the whole area of consultancy that looks at in-house health benefits departments and looks at them as a cost center and tries to manage downward internal cost instead of saying that these individuals have high leverage in their ability to manage health care, and health improvement. Benefits leaders are constrained by their budgets, by the fact that they feel disempowered relative to third-party administrators, and that they behave very much like purchasers, that the only time they can really exercise leverage is at contract renewal time. What are we doing about it? If we could go to the next slide. The next slide, please. First of all, I was very successful about 2 years ago doing a meeting with the Business Council, 75 Fortune 200 CEOs, and what was quite interesting is they got the message very, very quickly and had a lot of enthusiasm, and several of those CEOs changed their health programs pretty radically and very rapidly once they understood the power that they had. Secondly, and this probably requires working with small to medium-sized employers as well as large employers with large populations in a community, is to build grassroots activity. We did that in Stamford, Connecticut a decade ago to completely overhaul the architecture of the healthcare system. There is a very innovative model in southeastern Wisconsin with Quad Graphics and Quad Med, in which multiple employers have set up both in-house primary care staffs, preferred specialist relationships, and preferred hospital relationships. And I think that's the most disruptive employer accountable care organization model. And finally, we've got to continue to educate employers and third-party administrators on the concept of value-based healthcare design to drive patients away from poorly performing providers. This is not an insoluble problem. We have to get employers to understand that they can do something about the cost of healthcare and the quality of healthcare delivery. It's a long process, but I'm very optimistic we can make it move forward. Thanks very much.
Thank you very much, Mike. Really appreciate it. And again, we'll look forward to a deeper dive in some of these issues, because we really do have progressive CEOs that recognize not only cost is important, but quality of care and the quality of life and fulfillment of the lives of those employees. And that brings me to Bob Chapman. I recently had the opportunity at Harvard to do a very deep dive, 1-week course on inauthentic leadership. And one of the requirements of the exercise of our 6-member groups that were out of about 64 people, CEOs from all over the world, was to go through our own lives and say, who are the most inspiring people that we have ever met, and what was the impact they had? And I was in a group with the president of Lego Company and leaders of aerospace companies, and as I went through my personal journey, it became very clear that at the top of my list was Bob Chapman, one of the most inspiring men I've ever met, dedicated to his employees and bringing an entirely new empowerment model from, oddly enough, from our own U.S. manufacturing industry. Who says we can't innovate? And I've asked Bob actually to not dig into healthcare numbers and facts and statistics, but to really dig into one of the most powerful things we've ever seen, and that is an empowerment model where we recognize the intrinsic value and the heart and the soul of our employees, and then asking Bob to tell us, well, as that kind of a leader, what are you looking for out of us in the healthcare industry? Bob, could you please be our last speaker before we go to our reactor panel?
Thank you, Chuck. I appreciate the opportunity to speak to your group. And on the subject of truly human leadership, the power of leadership to create safe, effective, and compassionate care for all. Do you want to go to the next slide, Chuck? Barry Wehmiller is an American company with about 5,500 team members scattered throughout the world with just over $1.1 billion in revenues. and as I indicated, operations in England, Italy, Belgium, Hungary, and all over the United States. We have created, through our leadership journey, a statement which relates to the healthcare field that you're all talking about, which is we measure success by the way we touch the lives of people. We touch many lives in the course of carrying out our economic enterprise. We touch the lives of our bankers, our shareholders, our team members, our clients, and we have decided that that is the ultimate vision for our organizational model. And let me now go to the next slide, and it relates to what Chuck shared with us as we spent the last 9 months dialoguing about the implications of leadership to safe care. I have had the opportunity in the manufacturing industry, and I know you have in the healthcare industry, to learn about lean. And there's a gentleman at Harvard named Jim Womack who wrote the book on lean. And Jim has a great deal of frustration that today only 3 out of 100 companies that embrace lean become truly lean organizations. Chuck and the others that I've talked to in the healthcare field have expressed similar frustration by the fact that a lot of these wonderful safety practices, new technologies, have not had a greater impact on creating safe care for those lives that we care so much about. And it is clear to, I think, Chuck and me and others in the dialogue we've had for 9 months that the key issue here is leadership. And let me go to the next one. One of the things I want to mention that we have learned is that only 10% of the people who work in our organizations go home each night feeling that the organization they are a part of, their healthcare organization, their manufacturing organization, cares about them. And what we have, and that reminds me of one of the great service providers in our country, the Ritz-Carlton hotel chain. They have an inspirational model which I want to relate to you because I think it relates to the subject we're talking about. It is ladies and gentlemen serving ladies and gentlemen. And I tried to extend that thought process because that's a very empowering process. Everyone in the Ritz-Carlton organization is just as important as those clients, those visitors that come for hospitality in the Ritz chain. And because of those people feel cared for themselves, they provide a care level, a hospitality level that is one of the top in the world. So I looked at the healthcare industry and my awareness of the healthcare industry as a purchaser of healthcare, and I came away with the expression, people with needs, caring for people with needs. The needs of your caregivers, who haven't really been talked about too much in the healthcare field, are just as important as the needs of the patients. And so let me go to the next one. It's evident to us, it's clearly evident to us, that unless we demonstrate through inspirational leadership practices the commitment to meet the needs of the caregivers, we will never, despite all these practices we're talking about, all the initiatives, we will never meet the needs of our patients unless we meet the needs of the caregivers. And the key to safe and human care is inspirational leadership. I have an MBA from Michigan. I have a great education. I've got a great 40 years of business. And it is very clear to me that we were taught to manage, not to lead. And the key for the healthcare industry is moving from management to leadership. Next slide, please. And then there's another statement that I want to share with you that I've heard in this leadership journey that I've experienced that I think applies to healthcare as well as it does to the industries, manufacturing industries that I participate in. We have paid people for their hands for years, and they would have given us their heads and their hearts for free if we had only known how to ask. That's true in all the leadership models that we exist, management models, where we feel our responsibility is to have practices, technologies, and tell people what to do. And they would have given us their heads and their hearts if we'd known how to ask. So inspirational leadership could empower these 14 million caregivers to fully share their gifts in rendering quality care efficiently and compassionately that would allow them to return home each night with a sense of fulfillment. And returning home with that sense of fulfillment, there's a better chance that they are going to be able to deal with marriage, of raising children, and have a sense of experiencing the kind of care within their profession so that they can come home each night and be a caregiver themselves and their family. Next slide, please. So our message that we have clearly experienced in this journey, as an employer of almost 6,000 people, as a purchaser of health care from you all, it's very simple. We want to provide our associates who we care profoundly about. We are stewards of these people, 6,000 people that work for us. We want you to embrace inspirational leadership so that we can put the care back into health care, so that we can care for the caregivers. All these excellent clinical and financial metrics will be a byproduct of fulfilled caregivers who will provide the kind of care that you all aspire to. The last slide. So our message, as we have been on this journey with Chuck and his team for some time now, is it's as simple as people with needs caring for people with needs. It is critically, foundationally important that we meet the needs of the caregivers if we are ever going to embrace the practices and technologies that you all are talking about to help reduce harm to the patients. We need to meet both of their needs to meet either of their needs. Thank you for the time, Chuck, to share our thoughts.
Thank you, Bob. And an email I just received on a separate screen while I was advancing slides a little slowly for Bob hit, and talk about synchronicity. Nurse's suicide follows tragedy. A suicide of a nurse who accidentally gave an infant a fatal dose last year in Seattle Children's Hospital has taken her life as of April 3rd. She was a caregiver. She was a healer. She absolutely adored her job at Children's, says one of her colleagues. And this is exactly what Bob is talking about. We have ignored the fact that we are not robots and that we really have the opportunity through inspired leadership to really empower our teams. As we videotaped Bob's company and gone down to the line in Wisconsin, in Florida, and across the country and seen the same things, we ask the people that are practicing lean and doing a fabulous job and economically driving a fabulous company to sustainability. When we ask them, what is it about the leadership model here that is impactful? And instead of talking to us about their job, they say, I'm a better dad, I'm a better mom, I'm a better husband, I'm a better son. And so we have really been asleep at the wheel regarding our leadership and recognizing that the patient safety issues may not be our CPOE and our technologies, but it may be the technology between our ears, and that our own leaders really need to be empowered and to face this. We've run a little bit later because our CMS folks took a little longer, so I want to get to our reactor panel. I'll click through the slides very quickly. I always put myself at the end so I can cut me out if I need to. My little boy, we have what we call Charlie's House Rules, safety first, in an article that you'll see and have available on Safety Leaders. We charted the course a couple of years ago in an article called The No Outcome, No Income Tsunami. Are you a surfer, swimmer, or sinker? And we wrote this article with enough period after the prior tsunami that ended so many lives to be politically correct, and wouldn't you know we'd had another tsunami that had ended lives. But we're really seeing a tsunami of harm through patient care that is not the errors or mistakes, but actually system failures. The next slide, slide 48, addresses those slides. We reinforce what you've heard from the prior speakers of the fact that leadership, being engaged is absolutely critical, and we're seeing that from CMS, and we're seeing the soft side of things also coming from Blue Cross Blue Shield. I'll finish my comments to get us back on time or closer to on time just by addressing the National Quality Forum Safe Practices, the 2010 Safe Practices. Are a set of practices that actually address every one of the new CMS areas that are tied to payment and the partnership. They also tie to leadership, the first major practice, and they also tie to tying in patients and quality and involving patients and families. Our leadership toolbox on slide 52 is available on the web to be downloaded, and will be distributed to all U.S. hospitals. And I bring that up and the other issues such as Care Moms and other programs that we're offering. We're asking people like Mike Critelli and Bob Chapman from our industry to come to us and help us with what they've learned to bring back into healthcare as we partner with our purchasers. I'd like to ask first Chris Azui. I think one of the greatest unsung heroes of patient safety and quality. She's the Executive Director of Quality and Safety in the Clinical Affairs Division at Blue Cross Blue Shield, but more importantly, she's one of our greatest patient safety champions within the purchaser community. Blue Cross Blue Shield collectively through 60 companies, 39 healthcare plans, buys $500 billion of care, and Chris knows that there are pockets of high performance. Chris, would you react to this and maybe give us just a quick capsule of the kinds of things like Alabama, where a hospital association, the Blue in Alabama, and technology companies and hospitals have teamed up and are saving not hundreds but thousands of lives in infections. React to what you've heard, and can you give us the quick capsule on that story?
Absolutely. Thank you very much, Chuck. I love the fact that Dennis Wagner started and ended with vision, and I think that's what we all need to do. And I also just want to highlight just how empowering it is to hear Bob Chapman say that it's about people with needs, caring for people with needs. Within the Blue Cross Blue Shield family, most of our chief medical officers and nurses that work within health plans also receive care from the hospitals within those networks. Their family members are receiving care from this healthcare system. We grow up there, we go to school there, we count on the very people who provide care, not just to be within our network and provide a service, but provide a service to us and our family members. We have a number of very innovative Blue plans that have medical staff who came to the insurers because they weren't seeing change move quickly enough in their own medical practice. And so they thought, maybe I can leverage my skills and come to a health plan. Very interesting activities in Alabama. University of Alabama came to the Blue plan and said, we think we have this new early detection system for infections. We're not sure that the hospitals would be willing to try it out. Will you pilot this with us? And I go back to another idea, and that is trust. A health insurer sitting down with 6 hospitals saying, will you try this? Will you share your data? Will you talk about your experiences if we try a new early identification and mitigation process? And that trusting relationship led to now a partnership where over 60 hospitals have been using this program. They've been in place for years now, and we think we have saved thousands of lives because of the heavy lifting done at the hospitals, but also because of the trusting relationship where a Blue plan, an innovator, and hospital personnel sat down and said, let's not just talk about the contract, let's talk about what we can do to actually improve care and save lives. And there are pockets of these activities in all types of communities across the country where Blue leadership is sitting down with executive and clinical leaderships at hospitals and group practices to really try to improve care and save lives.
Chris, one quick question, yes or no, but I know the answer. Alan Korn has told me that they just haven't seen enough of hospitals or employers coming to the Blues and saying, we want to partner on performance. Let's do some innovative projects. Let's do some deals. Yes or no? Is it true that the Blues would be receptive?
Yes. they would be receptive. And interesting, at Michigan, the Keystone Initiative, highly successful, and the individual there at the Michigan Hospital Association said other hospital associations have contacted him and said, how do I work with the Blues? And my response was, call me, talk to me. We want hospitals that are willing to learn and willing to make changes to contact our clinical areas so that we can engage. So answer is yes.
And the other answer, and the next question, which I'll answer for you because I've asked the question, how often does that happen? And the answer is it's rare. So I think Bob, Mike, all of us that are on the audience here, we've got a set of organizations that represent 100 million covered lives saying we want to do some deals, we want to partner, we'd like to do more. And that's why the poll in the lower right-hand corner, if everyone could respond to the poll, if you want a deeper dive on the mechanics, the steps that you take, how do you design? Entrepreneurship is our favorite thing to do. How do you put a deal together so everybody wins the way Dennis described? We'd like to take, if the audience is interested, a deeper dive with a couple of deep dive scenarios with real cases that have real dollars, that will have real lives saved, and share that. I'll share with this audience before I move to Mark the fact that I've looked at the recent data, and the recent estimations are north of 2,500 lives saved by that initiative, more than $25,000 and I'm sorry, $25 million, and this is just where a team got together and said, let's try this. I'd like to move to Mark Bennett. Mark is the President and Chief Executive Officer of Health Insight, and the background here is that I personally don't know Mark, but I've asked a number of people, if I were to get a QIO, Chief Executive Officer, on as a listening and a reactor panel for a QIO-focused webinar, who are the best QIO leaders in the country? And Mark's name keeps coming up. So I don't think there's a better endorsement than by his peers. Mark, please react to what you've heard, because you're our anchor reactor before I open it up to ask some more questions and of Mike and of Bob. Mark?
Great. Thanks, Chuck. I appreciate the opportunity to offer a little bit of perspective. I'd start by saying I wrote down 5 or 6 things I'd just like to say from what I heard on today's call. The first is, just to put this in context, I speak to you from the community partnership perspective. QIOs are tasked, as Dennis described, and others, with a very challenging job of trying to connect the dots in communities around the country to try to help us get from the national vision and the national partnerships in that space down between that and the bedside, between a patient and a provider. How do we build the connections, the partnerships to make that happen? And so the QIO program becomes a kind of boots on the ground function to help us move that forward. With the vision of trying to achieve 40% reduction in healthcare associated conditions, or 20% reduction in preventable admissions in a short space of time. These are goals that we recognize can only be provided with, accomplished through broad partnership and through alignment of all of those partners. In every one of our communities around the country, we see many things going on to try to influence care, and we recognize that these goals are only going to be achieved if we can pull those together, and the QIO in that sense becomes a vehicle to fill in the spaces where things aren't as active, or to encourage or otherwise intensify the existing efforts that are going on to make this happen. I wanted to add just a thought to what I think Paul McGann said it, and I'd like to just sort of echo that from the perspective of a QIO. The cultural change at CMS going on right now feels very real to me. There is tremendous energy that has been brought into that structure and that organization, and the passion is palpable, and I think that's really important for the nation to understand, and for us broadly at the community level to understand. In terms of how we partner with other purchasers to try to change healthcare. CMS has one purchaser, but others coming to the table. I think it's important to understand that every community is going to be different, that the makeup and the nature of the purchaser community will be quite different from state to state, community to community, and we've noticed that a lot. We've done a lot of work with trying to reach out and engage purchasers in Utah and Nevada, and more recently in New Mexico in our organization, and every one of those places feels very different, whether it's business coalitions that are driving opportunities, groups of small employers that have gotten together, or Taft-Hartley plans, or government employee plans, or mid-size and large employers who are the drivers and have passion. I think the key becomes to find those people who can be part of that. And so that kind of the nature of alignment, I think, will look different. There are a number of things that we've found employers really, and purchasers especially, can help us with. One of those is to create and sustain the tension that's necessary for change in the system. Our healthcare system is remarkably resilient in a negative way to change, and employers and purchasers, I think, are powerful tools to help create that tension for change, whether that is based on asking the right questions, engaging in the right dialogue, encouraging and using publicly reported data, and changing the way healthcare is paid for, insisting on that from TPAs or others that you engage, or to the more sophisticated ideas that Michael talked about. And then I think also I picked up from Bob's comments just powerful ideas about how we reach out to create greater leadership in the community, and we are actively working on ways to reach out to healthcare organization boards and the C-suites, and trying to engage with leaders. And I think bringing purchasers to that discussion, face to face in those one-on-one meetings, or trying to build capacity, leadership capacity within the healthcare system, I think, is an important idea. And then I just close with Chuck's note about that intersection of how the slide about how technology and practices and leadership all come together. I think that's the key to making fast progress to really changing our system, is to find that place and pull together all of our resources at a community level to create something new and better. So those are the notes I took, and the place I see opportunity and energy emerging.
Those are wonderful thoughts, Mark. We really appreciate them. And you mentioned Bob as well as Chris. I'd like to just kind of move back up our chain of speakers. Bob, we asked to speak just for 7 minutes. We knew that our CMS speakers, we couldn't judge exactly how much time that they would have and shuffle the deck. And I'd just like to move up the channel a little bit back, of our speakers to Bob. And Bob, you all have pioneered some amazing things in industry. You've done over 50 acquisitions, all successful. You've been able to your specialty is to go into cultures where the employees feel disenfranchised, things are scrambled, they're under pressure, they've got financial dilemmas, they've got all kinds of, so many of the identical common denominators that we have in hospitals. I mean, if we were to not describe the area, but describe the symptoms of what's going on, it's almost a dead ringer that your target for acquisitions are a dead ringer for hospital. When you go in and then establish a new environment and use lean and other principles and develop new relationships with your trading partners, you kind of embody what you and I would probably say faith. The substance of the belief in things not yet seen. I know you're a man of faith, but you have the faith and the belief in the potential of the human beings being able to be the fastest thing to turn around an organization. Can you just share that experience with us? Because this is novel and unique, and just mathematically we look at your numbers and we just say this is just, there's the evidence that demands a verdict here.
Well, I think, Chuck, in the dialogue we've had for about 9 months now, and as I've listened to you and others that you brought around us to the challenges we face in the healthcare industries to prevent harm, I worry because of our organization around the world and the leadership principle we believe in, that my concern is genuinely that in all fields, whether it's healthcare or lean, unless those people who we bring about us in our organizations, in our hospitals, in our nursing homes, et cetera, unless they truly feel cared for themselves, there is no question in my mind that all these practices, all these initiatives I hear will always end up as frustrating as Jim Womack has in Lean, that it is not brought about the type of leadership that would allow people to share their gifts fully. The people in our hospitals, to me, under the pressure you just talked about, we have the same pressures in American manufacturing. We are trying to compete in the world. We are having to deal with healthcare costs, material costs, energy costs. We have the same pressures healthcare does, but we have learned, we at Barry-Wehmiller have learned in our journey that unless we allow people to know that we genuinely care about them, that we come together in these enterprises, whether it's healthcare or manufacturing, to come about and do something meaningful with our lives. Those people will never be able to provide for our clients, for our customers, the care that we aspire to. So I see all these initiatives in healthcare, which are the same thing in manufacturing, just manifested themselves with different words. We have all under pressure. Our people are under tremendous pressure, but they don't feel like 10% of the people only, and they're probably wrong, 10% of the people only feel like the organization they're part of cares about them. How are we ever going to have a society that we aspire to, all of us, unless the people in our organizations feel we genuinely care about them, and in doing so, they are able to care for others. It's just black and white to me in the association we've had, and I immensely appreciate the opportunity to share that with this large group of healthcare providers, because until we do that, we will never achieve the goals that our government has, that our hospitals have, that our healthcare providers have. They're going to continually be frustrated.
Well, thank you, Bob. And how talk about the book Synchronicity and things happening for a reason. As Bob was speaking, I got the email from one of our other experts regarding the nurse's suicide, and the comment that she was basically a healer. She told me she lost everything, and that this woman who ended her life, this critical care nurse, absolutely adored her job, and soon after the infant's death, she was put on administrative leave, and then they dismissed her. And the treatment of our nurses and our staff, when the majority, the out-and-out huge majority of the harmful events that occur that we see are due to system failures that we as leaders are responsible for, because we know they are going to make predictable errors. We know that as pilots. As a jet pilot, I'm taught that. And yet these things, Bob, that you're describing, until when you've really opened, even though we wrote the national standard for the 5 rights of the second victim to champion the cause of nurses and patient caregivers, you've really reignited the passion of all of us to start to take care of our own workers. Mike Critelli, you want to react to what you're hearing and anything you'd like to add?
Yeah, I think the engaged workforce is the key, not just for health and healthcare, but for really success. I mean, that's companies have understood this. They take engagement surveys every single year. They try to bring up engagement scores. They're measured on engagement. I think what's unfortunate is that CEOs still do not completely understand that the weak link in their organizations is that they need to have operational people as champions. HR and benefits people are wired for compliance activity, in many instances for, just having a lot of urgent issues with which to deal. They are a necessary and valuable part of the equation, but what companies need is to partner them with operating executives. When I did what I did at Pitney Bowes, we always had champions outside the HR and benefits department, and they reinforced one another. We had visionary people starting with my head of HR and as well as benefits and medical people, but you need to make this a corporate imperative. The thing that we all understood on a financial sense is that being able to manage, let's say manage your healthcare costs down by 25% and improve productivity is the equivalent of having a successful, multi-$100 million or billion-dollar business, and it's a whole lot easier to accomplish that and a whole lot more satisfying and life-affirming than trying to start a business with all the risks that that entails. And so we always said this is the path where by creating a culture of health and well-being, by improving the services in a community, we're getting a lot of energy, enthusiasm, engagement. It drives everything else. And I think that's the thing that people need to understand. People feel that, and I would agree with Bob's comment, people feel you care about them. The research is several decades old. If people feel you care about them in a workplace, then they're going to give you their discretionary effort. And what we now know, discretionary effort drives performance.
Perfect description. And I think that as we've been preparing a fellowship for that will be in partnership with Harvard University, the multiple colleges, the Mayo Clinic, the Institute for Healthcare Improvement, the honor of perhaps sharing the story and some of the methodologies that Bob is giving to healthcare and helping us with his empowerment model, the best of Bill George and Jim Collins and Franklin Covey. As we get the best of the best, we are finding over and over again that it is the servant leader that creates the environment for that true fulfillment for people to really feel that they really are appreciated and really, as I think, Bob, you've said before, that you have them for 8 to 10 hours a day, which may be more time than their family has them, and you can influence our community, our country, and the world more at the workplace than perhaps anywhere else. And so we'll conclude this this webinar to keep on time. I've got 33 minutes after the hour. I know, Bob, I'd like to thank you so much, not only for the webinar, but for so forcefully and in such a giving way providing your empowerment model to healthcare to measure your success by how you change and affect people's lives. Mike, thank you for your terrific work and for always being the thoughtful and impassioned, focused employer. And then that last thought of yours of just the mathematics of talking to a CFO and say, look, if we do this in healthcare, it's like we had $100 million or $1 billion business, and we already own the asset. Terrific thinking. Chris, I'd like to give you just a quick moment if there's anything you'd like to conclude before we then move to have Dan Ford close us. Chris, any comments that you'd like to reflect that might reflect what Alan may have wanted to share?
Thank you very much. I think we are very interested in building on trusting relationships and creating them where they don't exist so that this work can go on. I think it's also very important that we finish with a reminder that we're doing this for patients. And I would like to say at our recent national meeting, we also had Sorrel King speak to us about what happened to her daughter, Josie. And we are continually reminded of the importance of this work for our patients, not just Blue Cross Blue Shield members, but all patients using our healthcare system. So I thank you for this opportunity to be here.
Chris, thank you very much. And as I move to Dan Ford, a quick factoid. My wife Betsy and I funded the video of Josie King's story. It's now in 2,000 hospitals. We've studied 675 hospitals, and more than 80% believe that at least one life has been saved by that videotape, which means for our little investment, there's probably one life for every $20 that we donated to the process. Who says we can't innovate and that the power of stories does not have impact. Dan, please finish and close us out and express the wishes or thoughts of the patients that we really serve, and also the caregivers, as Bob would remind us. And then I'd like the speakers, if they've got a moment, to stay on, and we'll just debrief to see what we can do better next time. Dan, please close us with a quick 30-second to minute.
I will, Chuck. Thank you. I applaud each of the speakers. This has been very informative as well as refreshing. I would suggest inspired leaders, and I recruit inspired leaders throughout the industry in top positions, that inspired leadership not only includes the board chair and CEOs, but it should also recognize frontline nurses as well as patient advocates, just a whole host of leaders throughout the organization. I would suggest the human piece is so important, too often overlooked. We sometimes look to patients as uninformed interlopers. A friend of mine, Catherine Townsend, a provider in the industry, suggested this to me, and we can't do that. Bob Chapman's statement about people with needs, caring for people with needs, is right on target, and there were elements of that in most of the speakers. Even from patient safety advocates, we've gotten hurt, we've had our lives damaged, destroyed sometimes, and there's a lot of woe is me, there's a lot of anger, there's a lot of hurt, a lot of disappointment. All that's understandable, but we also forget that caregivers have needs too, and we can't forget that ever. I commend CMS actions. I commend all the employer actions. We've got to rebuild trust and integrity that Alan Corn alluded to. Please involve the Sorrell Kings in your patient safety advocates. Sue Sheridan, whose photo was listed there under Care Moms, is another one. There are a number of people across the country. Every community has people like this that should be involved with providers, with payers, with purchasers. Just a quick comment about our own situation, and I will end this very quickly. My wife has permanent brain damage as a result of medical errors, a combination of medical errors. We had a 9-year medical malpractice lawsuit that was nudged along by the defense attorneys and a very uncooperative risk manager. None of that should have happened had we had the same spirit and the same type of activity that we've talked about today. Thank you very much for involving me.
And with that, God bless all of you. We thank you for your attention. And again, this webinar the recording will be made available for free. A transcript will be available for also on the website, as well as all of the slides. And with that, we close a little longer than usual, but thank you so much for all of the terrific comments from Bob and Mike and Alan and Mark, Chris, Paul, Dennis, Joe. Thank you so much.